What we should do is debate these cases. So Jit, come up here with me perhaps, and we can ask people what they think. So we've drawn up 3 hypothetical cases which are different from one another. They've all got a different spin on it. He's had to be writing notes. I hope you noted that. So case 1.
I saw you backed out already. In your first week, put them in the cast.
Case 1 is a 24-year-old elite cricket player who presents with a rupture sustained about 48 hours before. He's in quite a lot of pain. Pain's significant, of course, because one of the problems is that after a couple of days, or 3 days perhaps, Achilles tendon ruptures often can become painless. And that's one of the reasons why the patients present late, because the pain goes and they think it was just a sprain. So the club have come with this player because he's a very good elite cricket player, and his manager's there and his physio's there, and the club's demanding that this guy gets back to playing cricket as soon as possible because he's a professional cricket player. So what are you going to do? Who wants to? Does anyone from the audience want to tell me?
It is not a compound injury?
No, it's a closed injury. He sustained it while he was bowling.
I would like to know this level of injury.
It's 6 centimetres from his Achilles insertion.
Tendinous?
No, it's not. But that's a very good point, because the myotendinous ones are the ones that are painful, aren't they?
Right. And I would also like to know if it is most distal, where there is no distal stump in fact.
No, it's not. We're talking about ruptures within the substance of the Achilles, not avulsions of the Achilles tendon. So that's quite important, because Achilles tendon avulsions are a different group of patients. So we're all talking here, as Jit said at the outset, about ruptures within the substance of the Achilles tendon. So really somewhere between 1 and 8 centimetres from the calcaneal attachment, I guess. Is that what we're talking about? So this guy's got a rupture which clinically is, say, 5 centimetres from his Achilles tendon attachment. So who is anyone going to treat it? Yeah, surgery. Is any? Okay. Is anyone going to treat this patient non-operatively? Okay, great. Would someone tell me why?
You have to talk to the patient as well.
Well,
if you offer
clearly.
him surgery, is it acceptable to him or not?
Okay. Well, obviously,
and he should know that there is a choice.
Okay.
Ravi.
Ravi.
You never mentioned that after surgery the patients heal faster. Yeah, you never mentioned that in your talk, so I presume the rate of healing, the time for healing is the same.
Exactly right.
One up.
Well, that's exactly right. Because they don't heal faster. I can't make things heal. Nobody in this room can make anything heal. All you can do is put the ends together. It's nature that makes it heal. So I can't make it heal.
So why not treat them without surgery?
Well, if you rupture a flexor tendon in your hand, are you going to treat that non-operatively?
Is that we're comparing oranges to apples?
Ah, good point. No, excellent answer. Well, the reason I would operate on this man, I like that. Like, I'll leave. The reason I'm going to operate on this guy is because if he re-ruptures, and I think he's got a higher incidence of re-rupture if I don't operate on, it might be the end of his elite cricket career.
What's the chance of re-rupture? 4%?
No, 12%.
No. Can I say something?
So that's more than.
So in our 118, it's 2. So you can do your maths.
2%.
Yeah.
And in our series, it's 0%.
Yeah. In your series, there is a deep infection of 3% that will ruin his career for not only career, it might just not make him walk again ever. Over to you.
Okay, so of the infections we've had, they're all ambulant, they've all healed, their Achilles haven't re-ruptured, they all walk still. None of them are elite cricketers, though, I must admit.
I take your point. Yeah.
So who's going to treat us operatively? Does someone want to explain to me why you're treated operatively?
Yeah.
Go on. If you want to operate, let's say I'm the player, okay, and you say you want to have, I think you should have an operation. I'm going to say, okay, I'm a cricket player. Why do you want to operate? I've phoned Mr. Mangwani, and he said he's going to put me in some sort of crazy thing, looks like from Star Wars, for 6 weeks. So why are you going to operate on me? You must have a reason.
You're not treating me without a shoe. After surgery also you're putting me in a shoe.
Say again?
After you operate
Your rehab.
you give the same kind of a shoe that Mangwani gets.
Yeah, well, no, I don't, because we don't have those Star Wars boots, but we have a boot, so I put him in a plaster for 2 weeks, just like I would if I didn't operate on him.
Which is less sexy than ours. Yours is more.
2 weeks in a plaster,
And after that,
a boot for 4 weeks.
then it makes 6 weeks.
6 weeks in total.
6 weeks the poor patient is immobilized. And he's insured also, not insured.
He's going to go in that whether I operate him or not. Doesn't make any difference whether I operate him or not. He's going to go into that either way.
Consume 6 weeks of immobilization.
That's right.
And what this poor doctor has done?
6 weeks of immobilisation, the same. So does anyone here? Is anyone here capable of fixing an Achilles tendon and not immobilising them afterwards?
No.
No. Okay.
That shouldn't be the take-home.
Okay. Okay. Well, should we move on to the next one?
Yeah. Well,
It's good. I like it, Chip. I'm losing.
yeah, one up for me. Can we?
Before we proceed forward, I would like to put a question to you. Do we assess the gap before we opt for the non-operative or the operative?
So I assess the gap before I operate.
If you plant a flex and you are not able to oppose the both parts,
Yep.
even then you would go on for non-operative?
No. So if I
This
plant a
question to Mangwani.
sorry, okay. I thought you were asking me.
Yeah, so our patients by default go into that boot from the emergency department. And the theory behind that is that in acute, how many times in an acute rupture, when day one you see them, you do, yeah, day two, and you plant a flex the ankle to a 30 degree, most will come together. Yeah, if you put it as your finger in there and push it, you will be able to push your tendons ends away, but you will be able to bring them together. Okay. And the literature doesn't support which gap is important or isn't important. There's an arbitrary figure of 1 centimeter that most people use, which is not well supported in the literature either.
I think instead of poking your finger, it would be advisable to use an ultrasound.
But I don't have any objection against using an ultrasound to see the gap.
And do you?
No, not at the moment. We're looking at it. At the moment, the protocol is that everybody goes in there.
So you think that if they're presented to you at 2 days, those tendon ends are definitely coming together?
If there is a gap of 3 millimeters on an ultrasound, are you going to change your plan based on that?
No.
No. So there's no, there is no significant gap or no significant gap, non-significant gap.
Okay, let's go on. Let's go on.
Okay, Mangwani, you said you will be examining the patient after 2 weeks. So what do you look for when you are re-examining the patient after 2 weeks?
I think two things. One is obviously going to confirm the diagnosis. These patients are being seen by emergency doctors with a diagnosis of complete acute tendon rupture. So once or twice, every couple of months, you will have one patient who's not been diagnosed correctly for that condition. So we've had one recently who had an undisplaced ankle fracture, was diagnosed as a rookie. So reconfirmation. The other thing is liner, when it changes, and most of you will have used or seen that boot, it is quite a pressure on your skin. So you want to make sure you're not macerating the skin with that. So that's another one to look for. And I think essentially that really. And if there is a massive gap, if the patient has been non-compliant and they've been walking without the boot, you will at that stage feel that big gap in there, and I straight away will go in and fix those. I have no problems with that.
I think we are running short in time. So.
Okay. One more? Okay, so we have a 43-year-old man, 1-week-old rupture, sustained pushing a car with his kids, but not sort of professional level, and no comorbidities. Show of hands for people who will go for operation straight away. Mark always goes for first. It's just the loyalty to Sheffield, it's nothing else. How much is the gap? This is 1 week old, so do you know what gap you could have? Yeah, so say for argument's sake, it's less than 1 centimeter gap.
How about for argument's sake, it's 2?
Yeah.
For the patient's choice, and how much is his operative following the treatment?
Yeah, so it's a compliant patient. You're not dealing with somebody who's a druggie or wouldn't listen to you.
So if just to question that further, if they are compliant, are you more likely to operate, or more likely to treat them non-operatively if they're compliant?
If the patient is non-compliant, then I like to operate.
Then you like to operate, right? Okay.
Because after operation, patient become more compliant.
After surgery, they get more compliant.
Okay.
Well,
How do you
one
want
of my patients had a unique position. He had ruptured while playing sports 10 years ago. And after 10 years, and that time he underwent surgery. After 10 years, he comes with a fresh rupture. How do you do
I think for re-ruptures in my books, particularly if they've
10
been,
years,
yeah, if they've been treated operatively, I go for surgery. But if you look at the literature, there is emerging literature for even delayed presentations and re-ruptures after surgery being treated non-operatively and having good outcomes from it. So it is a area we will debate forever. But I think there are some take-home messages which we want to get
I
out
did
of.
treat that patient non-operatively and he fared.
Another point.
In
In an interest of time, I think,
You deal it as a fresh rupture.
yeah.
Because it's
Anybody who wants to treat him non-operatively? Just a raise of hands now, please. Non-operation. Anybody else? They're on my side, but still not getting their hands up. I don't understand.
It's because they're on my side.
Surgery. Raise your hands up, please. Okay.
Go on, Jit. Fight this next one. See if you can win this one.
Okay. 68-year-old man, 1-week-old rupture whilst walking the market. Now, we're kicking in some comorbidities here. Blood pressure is one of the things being treated for, and recent antibiotics. Likes walking and playing with grandchildren. I think operation or no operation? No operation. No operation. Anybody go for operation?
comorbidity.
I have to vote.
Yeah.
I have to vote for myself, don't I?
Okay, great. Are we all happy?
How about show of hands in general terms and see if anything's changed?
Okay, so let's start with our 35-year-old again, where we started from. 35-year-old who, yeah, just last question to them. 35-year-old
In case we don't have access to these,
Aquilon.
Aquilon, and can we treat them conservatively without any functional bracing with simple cast?
You can, yeah. I mean, if you look at the literature for non-operative treatment, it has favorable results for your functional bracing, but not necessarily that you can't treat them in the cast.
And what is your rate of failure of the conservative treatment? Not
2 re-ruptures out of,
but
yeah.
like you have to resort to the operative treatment within 3 weeks.
Not much. It's the odd one who will be non-compliant, really. So I haven't gone into greater detail with results. Okay, we've got to wind up now. Okay, thank you very much. Thanks a lot.
Thank you, Chris, and thank you, Mohammed. I think the take-home message is that it's no panacea, non-operative or operative. The last talk in this session is at least tendinopathy by Patricia.
Yeah. Right, thank you very much, Mr. Chairman, and thank you very much for inviting me to come and talk here today. So I'm going to talk about chronic Achilles tendinopathy. I am an orthopaedic surgeon. I work with JIT in Leicester. So as we've already heard, the Achilles tendon is the thickest and strongest tendon in the body. It doesn't have a synovial sheath, it has a paratendinium. And as Jit said, it has a zone of relative vascularity, 2 to 6 centimetres proximal to its insertion, because it gets its blood supply both proximally from gastrocnemius and soleus, which it's formed from, and distally from the calcaneum. As Jit also said, it goes through a 90-degree twist, and that twist is where gastroc and soleus tendons combine, and those tendons wind round each other towards its insertion, and that may be in part be why it's subject to chronic damage at that point. As you've heard, that there are large forces transmitted through the tendon, and if you it's been calculated that a 70-kilogram man running will put 7,000 newtons of force through their tendon as they run. Let me just get rid of that. Tendinopathy is the commonest condition that we see of the Achilles and accounts for over 50% of its disorders. The majority of these are non-insertional with 2-to-1 instance, and I'm only going to talk about the non-insertional Achilles tendinopathies. It's commonest in the middle distance and long distance runners and is felt to be due to overuse, although quite a good percentage, a good 30% of patients aren't elite, well, aren't really athletic at all. There are risk factors similarly to Achilles tendon rupture. Some of patient conditions, diabetes, etc. We've heard about the fluoroquinolone antibiotics and inflammatory arthropathies. And as we've talked about before, the mechanics are important around the Achilles as well. If you've got a hind foot in a lot of valgus, then every time you take a step and you come up onto your toes in running particularly, then you get quite a lot of whip round of the heel, and therefore your poor Achilles is subject to repetitive more over the tendon is going through an exaggerated range of movement. So the patients present with pain over a lump which they develop in the Achilles, which is worse either at the start of or during sporting activity. They also get localised swelling and tenderness, and they often complain of early morning stiffness. When we look at them, you can see that the tendon is swollen proximal to its insertion. We want to look at the range of movement. Normally there's no restriction of movement of the ankle. They may feel it feels stiff, but it's just because it doesn't want to move quite as freely as the other. The area is thickened and tender. You look at where that tenderness is. The tenderness is normally over the lump itself, and as you examine it, you find the area of maximum tenderness, and as you dorsiflex and plantarflex the foot, if that area of tenderness stays in the same place, it tends to signify it's the paratenon that's the predominant problem rather than the tendon itself. If the area of maximum tenderness moves with the tendon, then it's obviously within the tendon, and it gives you an idea about what the underlying pathology may be. In terms of examination, I tend to use ultrasound because I've got musculoskeletal radiologists that I trust with, but obviously an MRI will likewise show you. And what we really want to know is whether you've got any cystic degeneration, whether there are large cysts within the tendon, or whether it's just a thickened tendon, and whether it's primarily a paratendinopathy, and whether the tendon itself is, although mildly thickened, whether it's a very thickened paratenon here instead. So obviously that is going to have a bearing on your treatment. Patients tend to be concerned about three things. One is pain, one is the third is whether they have an increased risk of rupture. Sorry. What can I do? Well, I think treatment is primarily aimed obviously at getting rid of the pain. You cannot get rid of the swelling, and I say to patients, whatever we do, the swelling will not go, but the swelling per se is not the problem. It's obviously the pain that we want to get rid of. There is no evidence thus far that if you have a chronic Achilles tendinopathy, that itself leads to rupture. Obviously, some things that we do in terms of treatment does increase the risk of rupture. So what can we do? Well, obviously, we start off non-operative, and then if that fails, there's options operatively. So rest or modified training. For those patients that are long-distance runners or who have suddenly increased the distance, when we see it with people that suddenly want to go and run the London Marathon, they suddenly go from next to no running to suddenly high distances, and they just have to back off and wait, and with then appropriate physiotherapy you can rehabilitate them. Orthosis, if they've got a very valgus heel, then the Achilles is constantly being whipped around, then if you put in an insole to change their alignment, then that will help. What about anti-inflammatories, either oral or topical? There's some evidence that there's some short-term effect, but it's probably as pain relief. Because if you look at histological studies, there's no actual inflammatory cells within the tendon, hence we call it a tendinopathy, not a tendinitis, because it's not true inflammation. If you look at other histological studies, there's evidence that shows that celecoxib particularly inhibits tendon cell migration and proliferation, i.e. it's going to inhibit tendon repair and therefore may actually be detrimental. Likewise, because it increases leukotriene B, which will lead to progression of any form of tendinopathy. So at the moment, although anti-inflammatories are used a lot, they may work as pain relief, but not necessarily as anything more beneficial. GTN patches have been suggested. And there was initial studies 10 years ago that looked at topical GTN patches on the area of maximum inflammation, and the initial studies suggested they improved both rest and activity pain and decreased the area of tenderness, and that difference was maintained in the short to medium term. Further studies haven't really shown such good results, and a randomised control trial really showed no difference. Part of the problem, of course, with GTN is that even if you put it on at night, patients still get significant headaches, and there is a massive failure rate with it because they just cannot tolerate it. And that goes even if you get them to cut them up so that you've got a smaller dose. I think most patients just can't tolerate them, so the initial enthusiasm has now waned a bit. Physiotherapy. Eccentric. When we talk about physio, the one thing that has been shown to be beneficial is Alfredson's eccentric loading program. He devised a program where he got the patients to exercise twice a day for 12 weeks, and it was all eccentric loading. There was no concentric contraction. So the basis of this is that they go up onto their tiptoes on the edge of a step. They then lift the unaffected leg off and go down into maximum dorsiflexion over the edge of the step. They then, with the knee straight, put the unaffected foot back on again, and it's that pushes you back up to the top so that you're not loading concentrically. And you do these twice a day, once with the knee straight, once with the knee bended, and as you progress you then start to stack and put a weighted rucksack on your back. And he's shown reduced neovascularity within the tendon and reduced tendon thickness, and the randomised controlled trials have shown better results than with any form of concentric program. So there's no doubt that the eccentric physio has some of the best results of any of the non-operative methods. What about shockwave therapy? Well, again, there's conflicting evidence really. There's some trials have shown no real difference, and others that, particularly this one that showed that was a shockwave versus a sham, but they also had eccentric loading, showed that although the AFS score was better than the treatment score, there was no difference in the Visa A scores. So there is conflicting evidence, and there's certainly no consensus as to what dosage you should use and what delivery regime you should use in terms of how often and what the ultrasound frequency should be. Ultrasound and injections. There's certainly really no evidence of any beneficial effect of pure ultrasound per se that the physios use, but ultrasound can be useful to guide injections. The one thing that we would say is that a blind steroid injection you really should not use. That has, if you've put an intratendinous steroid injection in and you don't know where it is and it goes in the tendon, there is a real risk of rupture, and it's a really bad thing to do to your patients. So any injections that we do tend to be done now under ultrasound control, be that by my radiologists tend to do them rather than me, but I know there are some surgeons that do some ultrasounds themselves. A variety of other treatments have been looked at in conjunction with ultrasound. Dry needling, which is you basically a small needle put in through the skin, multiple stabs around where the thickened area is in an attempt to promote some vascularity and promote tendon healing. People have injected autologous blood and platelet-rich plasma into that area. High volume injection, Breezemont injections. High volume injection is around the Achilles into the but the Breezemont is where you put the needle underneath the paratenon, between paratenon and the tendon itself. Turn the needle round so that the bevel's pointing away from the tendon so that there's no risk of injecting within the tendon, and you inject 20-30 mils of saline that will lift the paratenon away from the tendon. And often once they've done that, if you've got that away, you can then potentially inject some steroid into it, and that will help, particularly in the patients that you've got more of a paratendinopathy picture than any central degeneration. So there's a variety of non-operative treatments, but about 30% will fail non-operative treatment and will need some form of surgery. What are our options? Well, there's some minimally invasive techniques that have been described, where, again, with the patient anaesthetised, though, you can put percutaneously, use either a knife tenotome to make damage to it, or people have used sutures to actually put through it and then use a seesaw action to actually, again, creating some vascularity within the tendon. Pendoscopy, where particularly Van Dyck's been using it to put scope between the paratenon and the tendon sheath to divide the adhesions. And open surgery, either paratendon for both paratendinopathy and tendinopathy. The aims obviously of surgery are going to be to reduce the adhesions between the tendon and the paratenon. You excise any of the diseased paratenon, decompress the tendon, and excise abnormal areas. I mean, many of the time the tendon is swollen, but there's no actual damage within it. But if you make lots of cuts within it, if there's any areas of cystic degeneration, they can be curetted out. Do they need to be augmented? Well, the vast majority of the time, no. If you've taken out 50% of the tendon or more with your debridement, then you may need to augment it with an FHL transfer. But I have to say, I mean, the vast majority of the time, it's nothing like that amount of area that's actually got damage that you need to excise, although the whole area is thickened. Post-op, I have to say I tend to rest mine for a couple of weeks post-operatively just to allow the whole wound to heal, because as we've heard before, the wound healing around any Achilles is can not be great, and then they start with the standard physio eccentric loading regime. Physio's got quite surgery tends to have the results are pretty much the same as non-operative, but in the group that have failed, so about 75% will be better. You get better results, somewhat unsurprisingly, in the people with less extensive involvement, and if you've got a pure paratendinopathy where you're just stripping the paratenon off. However, somewhat unsurprisingly, like all surgery, it's got its complication rate, and it's not insignificant. A reasonable amount of wound edge necrosis and superficial infections, small percentage where the sural nerve will be irritated by it. Reoperation, i.e. because it doesn't work, it fails and it progresses and they need something more done. And there is a small rupture rate, because obviously you're doing damage to the tendon with your surgery, and so there is a small rate of rupture. So overall 10+% complication rate. So in conclusion, chronic Achilles non-insertional tendinopathy tends to be an overuse injury. They get localised pain and swelling around that area of the tendon. Non-operative treatment is the mainstay of treatment, with an eccentric loading program being the first line and really the most effective form of non-operative therapy. If that fails, then surgery can be helpful, but the complication rate is not insignificant. Thank you.
Thank you, Dr. We are running very late, already 40 minutes late. The session is going on, and 3:30 after 4, it's the cricket league that is waiting for all of us. So I think you'll pardon us for disallowing the question.
Thank you.
Thank you very much, the faculty, on behalf of the IOACON organizers, for this wonderful session. We started with a nearly empty hall and we are ending it with a full hall. Thank you. The next session will be chaired by Dr. Piyush Mishra, and since Mandeep is absent, I would request Dr. Jha to kindly take the chair.
This is in fact a debate in which later a speaker is Ravi Mittal, who will speak in favor of orthodesis.
Mr. Chairman, ladies and gentlemen, this talk was also written last night, as I only came to know last night that I was actually in the debate, so I'll do my best. I'm talking on behalf of the ankle replacement community, and as time goes on, hopefully you'll have some points to take home. Ankle arthrodesis has always been considered the gold standard. We'll have to debate that. Pain relief is what all patients are looking for, so any method of treatment will have as its main objective as pain relief. We also will consider the biomechanical effects as also the biological spin-offs of these operations, and we'll look at some of the evidence. So if we looked at evidence, I mean, as you will all appreciate, ankle replacement is a relatively younger baby, and evidence is still emerging as to what the performance is of this form of treatment. Charlie Salzman published this in 2009, where it was a non-inferiority study. It was not randomized, but it was multicentric, and it was a three-tailed study, so you probably consider this to be level 2 or 3 evidence. And he compared the results from arthrodesis of the ankle together with total ankle replacement. There were several flaws in the study, and I would grant that because of the number of variables involved in it. But it was in isolated osteoarthritis, which is an important consideration. It was a medium-term study at best, and what he found was the total ankle replacement in the medium term offered better pain relief and function. But he accepted there were more complications with total ankle replacement, and it required more secondary surgery, such as further hindfoot fusions or osteotomies. Beat Hinterman in 2006 again published an intermediate term follow-up, and he found there was a significant improvement in sports and recreational activity after total ankle replacement, something that is finding increasing favour, particularly in North America, as more and more elderly people take up sport. Mark Easley published his paper in Current Concepts Review, where he demonstrated in a meta-analysis that there was a slowly increasing body of evidence in total ankle replacement. There is some evidence that better designs have shown increasing survival rates over an 8 to 12 year period, and that there are new retrieval techniques that are now available. So in the past you said, well, if your ankle replacement fails, that's the end of it, you're going to have a horrible fusion. But these concepts are changing with increasing evolution of revision equipment that's now slowly becoming available. In a systematic review, Steve Haddad showed that they had very little difference in the outcome in both fusion and replacement, and at 70, and there was a survival rate of 77% at 10 years. There were fewer poor results in ankle arthrodesis, but amputation rates appeared to be higher in ankle arthrodesis. Again, Hans Trinker showed that there was a greater fall in the ability of patients to return to sport and recreational activity after an ankle fusion rather than after an ankle replacement, but this wasn't very significant. So we now are able to define what each type of training is able to offer us. An ankle fusion offers pain relief, which is the fundamental duty of an operation. It deals with difficult issues such as deformity and instability. It, however, causes a not so insignificant functional loss. You've lost your ankle range of movement. But it's an established technique. It's been a technique that's been ongoing from 1879, when the first ankle fusion was done. But it does have secondary biological and biomechanical effects. On the other hand, total ankle replacement also seems to offer a similar percentage of pain relief. It seems to be functioning better in the medium term at least. However, it is associated with higher complication rates. It's very difficult to use an ankle replacement to deal with deformity or stability issues. There is the issue of survival. Like any other implant, this has got a defined and finite survival rate, which is still being evaluated as we speak. So why would you want to do an ankle replacement? Let's look at ankle arthritis. A majority of these patients are post-traumatic patients that you would undertake operations of this nature. Trauma doesn't confine itself to the ankle. So there could be degenerative pathology, which is around the ankle, in the joints, both proximal and distal to the ankle. And so you have to be conscious of that. There are also inflammatory components to patients, for example, in rheumatoid arthritis. And they're all seeking pain relief. Many of them want their range of movement back. And if you look at the Asian subcontinent, squat toilets are particularly difficult with bilateral ankle fusions. If you looked at arthritis in adjacent joints, you must remember the greater the number of fusions you do in the foot, the worse the disability and the greater the difficulties in functional duties that you're able to perform. So a pantalar fusion is a terribly debilitating operation. If you do an ankle fusion in a patient who's got midfoot or subtalar arthritis, there are significant biomechanical spin-offs in that you are likely to render some of these symptomatic. There are also biomechanical spin-offs in relation to the ipsilateral knee, the ipsilateral hip, and in some situations in the contralateral limb. If you have bilateral pathology, as I said before, fusions by themselves are debilitating, but you have bilateral fusions, it becomes extremely difficult because there is severe loss of function and there are significant changes in cadence and stride and gait. This causes a significant limitation of activity and sometimes belies patient expectations quite significantly. What about multifocal arthritis? Consider a patient who is 40 years old, who has got very severe inflammatory arthropathy. It causes severe pain, disability. There are significant issues with proximal alignment very often, and this is often a progressive deformity. So if you have got somebody who has got bilateral ankle arthritis, bilateral valgus knee arthritis, it's very difficult to consider an ankle fusion when you don't know where the knee is going to be, because it's a progressive condition. You could use the same argument in doing an ankle replacement. So this is just to illustrate that these are very difficult patients. If you can imagine, that's my ankle that I've screened myself, and you can see that that's normal ankle range of movement. If you looked at this, an ankle replacement doesn't give you exactly the same nature of movement, but any movement is good because it protects the other joints in the equation. So the patient's x-rays that you had seen in the earlier slide, and this is somebody who's had bilateral hip, bilateral knee, and bilateral ankle replacements, and you can see that there is a reasonable gait that's made available. It's a happy patient and is able to move her limb, in particular the ankle, very well. You must also consider the native biomechanics, particularly if there's been past surgery. Also look at the local anatomy. Many trauma patients will have multiple incisions, and it may be difficult to perform a huge, massive ankle replacement procedure. You must also remember a large patient who wants to do hill walking might not be the appropriate patient for an ankle replacement because of the demands that he places on the joints. Also consider the nature of the surgeon. You should have a surgeon who is well versed in the anatomy of the foot. Largely in the United Kingdom, it is the foot and ankle surgeon that does these operations. You need huge amounts of training, as it is a very long curve for total ankle replacements. And this is just a slide that I picked off my colleague, who's done several training courses and cadaver workshops in order to get good at total ankle replacement. So I would suggest that the question of this debate should be, when would you do an ankle replacement rather than why? This is just another slide from the Sheffield experience, which showed that in spite of all the adverse publicity for ankle replacement, a very significant proportion of these patients demonstrated good or excellent results in the medium term. We shall all await with interest for long-term results. So, in conclusion, is this an ankle too far to replace? Well, I don't think so. There's still a lot of work to be done. It's still in its evolution. The use of a national joint registry is extremely important to assess the trends of an implant such as this. Training is pivotal, and implant manufacturers have a big role to play in evolving the ideal ankle implant. 50 years ago, a knee fusion was a fantastic operation until the evolution of a knee replacement. It's very difficult to go back and say, well, I think I'll still do a knee fusion because it gave fantastic pain relief and it had few complications. So we also have to remember our patients and our surgeons, regulate both. Watch this space. Thank you.
Dr. Hariharan, now may I request Dr. Ravi Mittal to speak in favor of arthrodesis.
Good afternoon, everybody. I agree with what Dr. Hariharan has said, but I would add some riders to it. More importantly, I would like to mention the facts which he has not told you. So I'll be speaking in support of ankle arthrodesis, but Before we start, let's talk about some general awareness. In which aircraft does the President of the USA fly? This aircraft is also called Air Force One, and you must have seen various movies in Hollywood based on these aircraft. And this is the photograph of this aircraft. Let me tell you, this is Boeing 747, also called the Jumbo Jet. And why US President flies in this? It's safe, it's reliable, it's comfortable, can fly long distances. But mind you, it was launched in 1970. The same company launched a new aircraft in 2011, and the company claimed that it was the most fuel efficient because it was made of composite material, could fly longer distances in lesser fuel, and it was less noisy, and the comfort of the passenger was the foremost. But it was marked by production delay deliveries, fuel leaks, fire in batteries, wiring problems, missing low pressure filters, faulty self-identification systems, falling panel, broken window, and icing on the engines. Air India also has got these aircrafts, and it has faced the problem of falling panel, broken window, and icing on the engines. The newspaper day before yesterday carried this news. So the lesson is, everything new is not good. Go for the one which is time tested. So if you have to choose a procedure which is a safe, reliable, easy to do, has low cost and easy to salvage, and the other procedure is difficult, high cost, many problems, difficult to salvage, and doubtful benefit. I'll argue on this point, doubtful benefit. This is ankle arthrodesis, this is ankle replacement. Dr. Hariharan has already considered that ankle fusion is still the gold standard even in 2013. Multiple reports say that. Advantages of ankle fusion are that it's easy. You can correct malalignment in both the planes, coronal and sagittal. There is no issue of instability. Infection, if it occurs, is manageable easily. It's low cost, and prior skin scars are not major problem in this. But there are big issues in ankle replacement, very big issues. And there are so many exclusion criteria for ankle replacement. Ankle instability, deformity, more than 10 to 15 degrees, peripheral vascular disease, peripheral neuropathy, heavy worker, significant bone loss, AVN of talus and distal tibia, infection, poor compliance, and obesity. Obesity is a big problem these days. And all these you don't have to bother in ankle fusion. Then who is the ideal candidate? Dr. Hariharan said we have to bother when to do and not why. So you have to look for an ideal candidate. He is a thin-built patient, no significant deformity, no peripheral neuropathy or peripheral vascular disease, no infection, no bad scars, not young, and he has low demand and no AVN or bone loss. So are we talking about this elusive patient? If you're talking about primary OA, I think primary OA of ankle is very rare in India. I don't know about West. Is it common? No. Rheumatoid arthritis, I know these days you are managing it well with biological agents. So you have lesser and lesser number of rheumatoid patients going for replacements of all the joints. Post-traumatic osteoarthritis. Now, we know that many of these cases are being salvaged by corrective osteotomies and cartilage regeneration procedures. Then who is the ideal patient for ankle replacement? Is it difficult to find? Or are the indications being stretched too far, and hence we have got the complications? The claimed advantages of ankle replacement, mainly three. The first is ankle movements are preserved, which are required for crouching and walking on uneven grounds. The second is decreased risk for adjacent joints osteoarthritis. Now let me put forward, very few activities in modern living require that kind of movements. The average increase in the tibiotalar movements of an ankle replacement is just 5 to 10 degrees. Literature has shown that. So does it make any difference to the range of motion? The reports of adjacent joint osteoarthritis putting more stresses on the adjacent joints. The reports are contradictory. There is no report to verify this claim that there is increased incidence of adjacent joint osteoarthritis. And even if it occurs radiologically, they are not clinically symptomatic. The third claim made by the proponents of ankle replacement is the gait is better. There is movement of ankle, there is symmetrical timing, and there is restored ground reaction. But studies have proved neither fusion nor replacement restores normal gait or speed. Biomechanical studies have proved that. Gait analysis has proved that. Then why are we doing ankle replacement? So let's talk about the results. There is no randomized prospective study controlled trials. Dr. Hariharan agrees that. They are mostly retrospective studies, and there has been only one prospective multi-center study which was comparing the star implant versus the ankle fusion, and this study was done to obtain FDA clearance, nothing else. The only aim of the studies was to obtain FDA clearance. And what was the bottom line? The bottom line was to prove that it is not inferior to ankle fusion, and the hypothesis was just proved that it is not inferior. It was never proved that ankle replacement is better than fusion. And this was in 2009. And this is a great man, Salzman, who's writing this report. 2010, you have a review of 13 level 4 studies. The authors found there is large variation in outcome. Survivorship ranged from 67 at 6 years to 94 at 12 years. There's a huge variation. Wound infection 8%, deep infections 0.8%. 2013. Now look at this study. This is a single surgeon study by using 3 different implants. And he found that you don't gain any significant movement at ankle even after doing ankle replacement. This is a very big statement, that you don't gain anything after doing replacement. A very recent report published in 2013. This was a systematic review and meta-analysis. Though the authors, this was a multi-author publication, they said that ankle replacement had a positive impact on patients' life. However, the quality of evidence is weak and fraught with biases, and high quality randomized controlled trials are required to prove that ankle replacement is better. Now, this study was based on joint replacement registries, and the endpoint was revision. But in the joint replacement, all the information is voluntary from the surgeon, and it does not take into account the joints which have failed or are failing but are not revised. So your data is incomplete. In this study, the mean increase in range of motion was just 11 degrees, which is just minimal. Mean 10-year survival was 73 to 89%. And the most important thing was that at 4.4 years, you had 22% radiolucencies around the implant. That means they are bound to fail, and you know they are failing at 4 years. They may be revised or may not be revised. And progression of subtalar osteoarthritis was from 90% to 59% at 7 years. This is after replacement. So the claim of the proponents of replacement at adjacent joint osteoarthritis does not occur or does not progress is again proved wrong. And most studies use the AOFS, American Orthopedic Foot and Ankle Society score. Now this score is no more used for evaluation. You should use the patient subjective scoring like SF16 or SF32, and all the studies were using this score. So the recommendation of this paper was that you need some more randomized control trial, and you should have some patient reported outcomes, whether they feel better or not. And the most important thing is whether it is cost effective to do ankle replacement versus ankle fusion. What about the wound complication? One publication is reported around 28%. That's a very, very high figure. That includes both superficial and deep infections. And you have more infections in smokers, peripheral vascular diseases, and circulatory and vascular diseases. What if it fails? Again, you come back to us for fusion, because you have very limited options for revision ankle replacement. So you come back to fusion when it fails. Bottom line, how many people do it? Among the general orthopedic surgeons, hardly anybody. And among the foot and ankle surgeons, I have been told by the members of the BOFS, only few foot and ankle surgeons do it. So the big statement is very few surgeons do the most of the ankle replacements. And the designer surgeons have better results than the others. That has also been proved in literature. So the conclusion is the fusion of the ankle or the arthrodesis of the ankle is time tested, it's the gold standard, it is universally applicable, and you can also use it for salvage of the failed ankle replacement. Replacement, there are many ifs and buts, it's an evolving science, and till now it has not been proved superior in any report to ankle fusion. And these reports have a lot of biases. And what we need is prospective randomized controlled trials which have patient reported outcomes and which tell you about the cost benefit ratios to prove that ankle replacement is better than fusion. Thank you very much.
Thank you very much, Ravi. And both the presentations had a lot of clarity and transparency, I should say. As you have rightly said, ankle arthroplasty is still evolving, and there will have to be centers where very many numbers of arthroplasties have to be performed before really finally coming to a conclusion that it gives good results. But given the design, the final outcome of an ideal arthroplasty, that it will provide real mobility, not the restricted mobility. It will be at the same time stable, will not be associated with further surgeries, should be a preferred choice. Maybe the time is yet to come. Arthrodesis, no doubt, is still the best. Thank you. If there are any questions?
Is there any questions regarding this ankle arthroplasty and arthrodesis? No questions. Move on to the next speaker.
Thank you, Ravi.
Dr. Vijay Shetty. Is Dr. Vijay Shetty is here? No, he's not here.
Okay, so we are already running short of time.
Now we move on to the next session. Now I call the next chairperson, Apurva Agrawal and Ram Evan.
Good afternoon, ladies and gentlemen. We're half an hour behind, so hopefully the next batch of speakers will time themselves very well, and we will try our best as the chairs to keep the time. I would like to invite the first speaker, Mr. Mohapacha.
And it should be more of a liquid consistency, and they have to maintain on a low fiber diet. And of course SMBG is important to improve their glycemic control. Sick day, never ask your patients to omit the insulin. They have to again do their SMBG 3 to 4 times, test their urine ketones, and drink adequate amount of fluids. And in this, they can drink any sodium or calorie-free foods like mineral water, coconut water, soups, tea, fruit juices, provided their blood sugars are controlled, and of course they have to avoid exercise. So my last carry home message is the balanced diet is important in prevention of diabetes and maintenance of euglycemia. Avoid simple carbs and add complex carbohydrates. Eat a variety of fibrous foods and vegetables. Quantity and quality both are equally important. So judiciously select fats and carbohydrates, and preferably always to use a mixture of oils. Maybe you can have a PUFA, MUFA and saturated fats. Non-nutritive sweeteners are safe when consumed within the acceptable daily intake limits. So to end with, to eat is a necessity, but to eat intelligently is an art. Thank you. So we all have to monitor the art. Thank you. Thank you so much.
Any question from audience? Okay.
No, there is a book by National Institute of Nutrition called as Diet in Diabetes and Diet in Heart Disease. They're like 100 pages books. Where do I get this? At NIN, Hyderabad. So you can ask, it's very basic, but nevertheless it gives you some direction.
So, any question?
We again have to, it is all on the HMD. Hello.
A combination of ghee and mustard oil.
Yes, you can. Yeah, you need to take a proper combination.
Ghee contains saturated.
Yes, ghee contains saturated this and mustard and yes. So yeah, actually a good combination would be some amount of a saturated, some amount of PUFA and some amount of MUFA. So maybe, or otherwise you need to change, keep on rotating your oils because every oil has a different property.
What is the current status of olive oil?
Yes, olive oil actually in Indian scenario because of the the smoking point is very it's low, so it cannot be used. See, we Indian diet, actually this is not working. Hello, yeah. The Indian diet actually, when we see, we do a lot of frying, you know, and whenever we are making vegetables, we allow the oil to heat a lot, and then we put the vegetables. So basically, for olive oil and the other oils, they are not actually acceptable for our Indian diets, but they can be used as for dressing. If you are making a salad or something, they can be used for dressing. Yes, can be done, because it shouldn't be heated more.
Just one.
Ideal body weight.
Ideal body weight ideal body weight is according to that group, weight height in centimeters minus 100. Suppose his ideal body weight is 30 kg. Suppose his ideal body weight is 30 kg.
Underweight. That means he's underweight.
Underweight.
I mean, ideal body weight. I'm not.
Actually, his weight is 30 kg. When we calculate, his ideal weight becomes 34 kg or 35 kg. We multiply this from 40 kilocalories per day.
Yeah, if he is if he is underweight, yes.
But if we multiply it from his present weight, only then we will get that required. Can I come in?
See, there are two ways of doing it. If you ask me, I go by present body weight. But there is a different way of doing it. You can do it by ideal body weight, provided you go gradual. In my clinic, I use present body weight because for me, what I see is what I. So, but I go low on calories. So, suppose somebody has to lose weight and say they are 60 kgs and they want to get to 40. I'm just giving you an arbitrary example. Then I have to give much lesser calorie, right? So, I give lesser calorie per kg present body weight. If you go by ideal body weight, you can give more calories per kg ideal body weight. So, then your multiplying factors are different. If you are going by present body weight, you give 15 to 20. If you are giving by ideal body weight, you give 25 to 30. Same. It is just the way of doing. See, unlike, it is a very subjective science, dietetics. So, it is the knack which you develop over the years. I go by present, but by ideal you give more calories. By present you give, depending upon what you want to achieve, you give less or more.
Alzheimer's. No, I told you only on the very higher dose, and that. I don't think so. I don't think so. And we have not Alzheimer's. No. I think it's on your taste. Sucralose does not have a after bitter taste. So people are preferring sucralose because it is heat stable and it can be safely taken. Yes, definitely you can take